What's up, guys? Doc Brown here. We're going to do a video on some burns. Please forgive me if the dogs bark. There's people coming in and out of the house today. I really should have recorded this for you guys down when I was at HHC last drill. It was about a 45-minute class, but this will definitely be shorter than that because you're not asking me questions in real time. All of my information today comes out of the pre-hospital trauma life support book. Oh, there goes the dog. But for those of you that are not medical, this may be new, this may be review, but this section here, I'm terrible at drawing, but is your skin. So this top layer right here is the epidermis, which is the top layer of skin. Then you have your dermis, where your hair and your sweat glands are. Then you have your subcutaneous, which is your fat level. And then down here is your muscle. Moving on down, this is the same picture, just with some red lines through it. Each of these lines represents the degree of burn. So as you can see, your first degree burn just skims the first layer. That's going to be like your sunburn. Second degree burn goes down into your dermis, so your second layer of skin. Your third degree burns go down into your fat level, and your fourth degree goes way deep down into your muscle, sometimes your bones or your internal organs. Think of your skin kind of like an egg. You go to your frying pan, you crack an egg open, and initially it's all liquidy and translucent, and you can swirl it around if you wanted to, make scrambled eggs. But then as it heats up, once it makes contact with the pan, it becomes white and more firm, and that's how you get a fried egg, right? Well, think of your skin doing the same thing when you get a burn. The proteins are breaking down, and that's what makes it, in the case of the egg white from the translucent part. It's the same process in the skin. You have your immediate and your delayed burns. Your immediate happens at the point of exposure, and your delayed is inadequate resuscitation or inadequate treatments or wrong treatments, such as putting butter or ice on a burn. If you do this and I catch you, I will slap you. So don't do it. While I think of it, there is a better picture of the skin. Let's move down into our degrees. There it goes. There's the focus. Apologize for some of the marker being screwed up, like right here. I transported the board home like this, so I didn't have to rewrite it for you guys. But your first degree burns are going to be your superficial, which is just going to be up here in your epidermis. Think of it as your sunburn, your basic sunburn. Most of you know me, and that I am very redheaded, and we get burns very easily. They usually take about a week to heal, and the superficial first degree burns are not included in your body surface assessment, or burner body, one of the two, but it's the percentage of how much of your body is burned. Your partial thickness or your second degree burn is going to affect your dermis and your epidermis. Usually takes 2 to 3 weeks to heal, and it is painful. It can look wet, and it will have blisters. This is kind of similar to what a cold freezing injury would look like, but obviously you're dealing with heat in this case. Again, your 2nd degree goes down into this section here. Quick story, on my first marriage, we went to the Bahamas. I didn't think about putting sunscreen on. We were outside for about an hour, and I had my shirt off. I blistered from mid-bicep all the way across my chest to mid-bicep. And yeah, that was not fun whatsoever. Moving on to our full thickness, our 3rd degree burns. 3rd degree burns can appear with your 1st or your 2nd degree burns. You know, because you have it going through all the layers of the skin. So yes, it's in your fat layer. It's also going to be up in these other 2 layers. It can look thick, dry, white, leathery, and this will be burning your nerve ending. So in the 3rd degree section of the burn, you may not feel the pain at that point, but in your 1st and your 2nd degree areas, you will feel the pain. Let's see here. This is a better picture for you guys. It goes all the way down. It can look white and charred, dead tissue. Yeah. So let's see here. This patient has partial thickness, which is a 2nd degree burn. This particular patient has your full thickness with charring of the skin visible with thrombosis and blood vessels. So, again, one of those things that's not going to be fun to have. At this stage, you will need a burn unit. And the flaky stuff is going to be called eschar. 4th degree burns are going to contain or go through all layers of skin. It can even go down into the bone and down into your vital organs, like I mentioned a minute ago. These will be disfiguring and will need significant debridement, which basically means taking all the dead skin and removing it. Basically, they put you in a tank, a dunk tank, and scrub you with stiff bristle brushes. Not fun stuff. So this is what that would look like. And then, sorry, the light's a little wonky. But this is also your 4th degree burn. It looks like it's to an arm. And then, like I said, it can go all the way down to your bones. So moving on, we're looking at our burn assessment. We're going to follow our normal procedures of your March pause. Some people learned it as HABCs, but March pause is massive bleeding, airway, respiratory, circulation, head. That was pain, but it got goobered up. Antibiotics, wounds, and splinting. Under the head section, there's also hypothermia, and now there's helicopters, so basically getting ready for transport. I didn't know that when I first did this class, so I learned it as I went. You know, obviously, if like we have an IAD blast, you're going to want to stop any bleeding. You're most likely going to have burns in that situation. This more affects me and the other medics, but in the airway section of your assessment, if you have inhalation burns, so burns around the mouth, within 30 to 60 minutes, it's going to swell up and close. So we're going to want to strongly consider intubation as quickly as possible. If the airway closes up before you can get to them, you're going to have to do an emergency cricothyrotomy, which that is not fun. That's a whole separate class that we can go over. Circulation, we're going to... Sorry, guys. Under the circulation, well, respirations, you're obviously going to want them breathing. That kind of goes hand in hand with the airway section. Circulation, we're going to start 2 large bore IVs. In the kits that we get from North American Rescue, there's nothing less than an 18 gauge IV catheter. And then, you know, the rest of the March pause doesn't really affect the burns as much. Although most burn victims will be getting antibiotics because you can get infections from it. Rule of nines is one of the things that we use for assessing how much of a person is burned. We have our adult, our adolescent, and our infant. The head on an adult is going to be 9%. Each arm is 9%. Front and back torso are 18 individually. The groin or the genitals are 1% on all adult, adolescent, and infants. Each leg on the adult is 18%. Going down to the adolescent, the head is 12, each arm is 9, 18% again for the torso, front and back individually. The legs are 16.5%. With the infant, we have 18% for the head, 9 for the arms, 18 for the front, torso, 18 for the back, 13.5% for each leg. The reason why the head percentages get small or get larger as the person gets smaller is because, especially babies, have big old heads in comparison to their bodies. You know, how do we treat this? Well, step 1, we're going to stop the burn, regardless of what that is. If you're on fire, stop, drop, and roll. If you're dealing with white phosphorus or something like that, make sure you have something to smother it. But if you're dealing with white phosphorus, most likely, wherever you're dealing with that on the body, you know, it is going to be done over with before you can even stop it. We're going to get them trauma naked, so completely naked, no skivvies, no shirt, socks, shoes, anything like that. In the field, we're going to wrap a dry, non-adherent dressing onto them. So non-adherent, for you non-medical folk, that just means there's no sticky stuff to hold the bandage on. We're not going to put any ointments whatsoever on these patients in the field. A couple reasons. Number 1, we generally don't carry them out in the field. Number 2, if you burn yourself immediately and then go and put on, say, silver Silvadene cream, you can potentially make the burn worse. If you put the ointment on, it can act as an insulator and keep the burn going, and that goes against our stopping the burn. Also, Legacy Emmanuel's Burn Center came out a few years ago and said, please stop using silver Silvadene and use bacitracin or Neosporin instead. They like that because they can see through it and see the burn, versus the silver Silvadene cream is white, and you obviously can't see through it, and they would just have to scrape it off the patient and then causing the patient more pain and suffering. I personally love silver Silvadene for like sunburns and even your second degree burns if you don't need to go to the hospital or anything like that. The silver has antibacterial properties, which are much stronger than like what you can take if you have some disease where you need antibiotics. Silver, especially colloidal silver, has been shown to kill the drug-resistant diseases such as MRSA. So that's pretty cool. And then we're going to want to resuscitate with fluids. This section is not necessarily for you infantry guys, but it's still nice to know. We're going to use lactated ringers. In the first 24 hours, this patient's going to need a lot of fluid. We're going to use 2 to 4 milliliters times your patient's body weight in kilograms times the percentage of burn. So if you have 18%, so a full leg, for example, in the burn, you'd put that there. Then you put whatever they weigh in kilograms. The conversion from pounds to kilograms is 2.2 times the 2.2 times the pound or kilograms in order to get pounds. So be girls divide, I believe. And then I would say use the 4 milliliters on this section, just because you can always titrate down. We are never going to use normal saline. That's what NS stands for. LR is lactated ringers. Because you can make your blood acidotic. The lactated ringers is much more close to what your pH is in your blood. For pediatric patients, we're also going to add, 5% dextrose or D5W, because kids tend to lose their sugars much faster than adults do, and they can crash a lot harder. Again, with smoke inhalation, so anytime you're in a structural fire type thing, whether it's the vehicle or a building, we're going to need to watch out for inhalation of smoke. Administer less fluids. There's some circles that are saying it can help protect the lungs. Go back up to in our rule of nines. That's all fine and dandy, but sometimes you need to use the hand method. The patient's hand, so if you're the one that's burned, your hand is, where did it go? 1.5%, I believe. Yeah, that sounds right. It's 1.5% of the total burned area. Again, here's the formula that I just gave you. So in this case, they're using the formulas on top. Next one is they're using the 4 milliliters, and the patient is 60 kilograms with 30% burned. You're gonna need 9.5 liters of fluid in the first 24 hours. That's not even that big of a burn, especially if you consider the stuff that we do with like IEDs. Electrical burns, these are going to be the most dangerous and disfiguring burns that we're going to come across. Here's a picture of one, for example. Electrical burns are similar to crush injuries, and they release myoglobin and potassium, which those can both affect your heart and potentially put you into a dysrhythmia, which you'll need either a defibrillator or some other drugs to fix that. The myoglobin is a molecule found in the muscle that assists the muscle tissue in transportation of oxygen. So basically, it's the stuff that takes the oxygen from your blood and puts it into your muscle. When this is released, it can be toxic to your kidneys and cause kidney failure. This condition is myoglobinuria. Sorry, I'm terrible at these kind of words. It's also similar to what happened a few years ago with the football players down in McMinnville, where they worked out way too hard, didn't have enough water, it was hot, it was dry, and they ended up in the hospital for a few weeks with I can't remember the name of it, but it's very similar to myoglobinuria. One of the signs and symptoms is that you have tea or Coca-Cola flavored colored urine. This is kind of an example of what it might look like. Circumferential burns. This is where, say, your forearm is burned all the way around. Those are not fun because it can act like a tourniquet and cut off your blood flow. It can give you compartment syndrome as well. So if down here by my watch is has a circumferential burn, and there's a space in the middle where there is no burn, and then up here on my bicep there's burn again that's circumferential. That's a lot of bad news. How we fix it is a escharotomy. Basically, just like in this picture here, it's where you cut the flesh along the burn so it can expand. We can also deal with asphyxiants when we are dealing with burns. You have your carbon monoxide and your cyanide gas. Both molecules are classified as asphyxiants and thus cause cell death by hypoxia or asphyxia. Hypoxia is where you can't get blood or oxygen on your blood, and asphyxia is where you can't breathe. With carbon monoxide, it binds to the hemoglobin, so your blood cells, and you have a greater hemoglobin with much greater affinity to oxygen does. So it binds easier is basically what that's saying. We cannot generally recognize this if we use our normal oxygen, our O2 finger probe that fits on there. So we need one of these devices. Works extremely similar. It looks at how much of the carbon monoxide is in your blood versus how much oxygen. With mild symptoms, the levels of 15 to 20% carbon monoxide in your blood. That's all that means. And then increased symptoms greatly get worse and worse, and when it exceeds 50 to 60%, you can have seizures, coma, and death. For all you Futurama fans, that is also what you would get with bonitis. These are the symptoms of your mild, moderate, and severe carbon monoxide poisoning. Your mild, you're going to have headache, nausea, and fatigue. Moderate, you're going to have severe headache, vomiting, confusion, drowsy/sleepiness, and an increase in heart rate and ventilatory rate. And then again, seizure, coma, cardiorespiratory arrest, where you stop breathing, and death. With your cyanide gas, it's similar in where it binds in the blood. Where are we at? So that word I can't pronounce, so I'll just let you look at it. But it's Cyanokit. Basically, what this kit does is detoxifies and it creates vitamin B12, which is non-toxic to the body, and actually has been shown to fight cancer. So get your vitamin B12 in. Basically, you get those kits, and then you have the cyanide gas, which is from burning plastics. Then you give that, and they are cured, essentially. Toxin-induced lung injury. I'm not really going to talk about that. Move on to some child abuse stuff. 20% of all child abuse results in the intentional burning of the child. The majority of children intentionally burned are 1 to 2 years of age. Many jurisdictions require healthcare providers to be mandatory reporters in cases of suspected abuse. This means that if I suspect that you are abusing your child, I will report you to the police. Most of these child abuse in the burn category are from intentional dunking, or intentional immersion is the term that the book uses. As you can see more from this picture, it's where the child is dipped into boiling water or oil or whatever, and you get that sock-like burn, and then on the rump you have the burn there. The reason why this particular child is like that is because he tried to pull out of it, which, I mean, that's a natural reaction. You and I would do that. And then this says straight lines of the burn pattern and absence of splash marks indicate that this burn is a result of abuse. So you have your accidental burns, obviously, and those were some not so accidental things. Contact burns. This is like when you reach into the oven and you go to pull the pan out, but then you realize that you don't have a oven mitt, and so you retract your hand real quick. That's a contact burn. They can be really bad if you aren't quick enough to remove your hand or your leg or wherever from whatever is burning. Radiation burns. This is like your electromagnetic radiation, your X-rays, your gamma rays, particulate radiation. This book goes into a little bit about your dirty bombs and your thermonuclear devices. Those types of burns would be definitely covered in a CBRNE class. I would need to do a lot more research and reading up on that type of class in order to give you guys a better idea of what's going on there. But with the nuclear and dirty bombs, you can get acute radiation syndrome. Think of fallout as you get more rads, you get sicker and sicker. Chemical burns, these are pretty common whether you're in the industrial setting or you're at home. Your water is pH of 7, coffee pH of 5, baking soda is about 8.5, 9. As you go up in the scale on the numbers, you get more basic. As you go down, you get more acidic. So this is, the acidic side is going to be like your vinegar, your battery acid, and your basic side is going to be like bleach or Drano. Industrial settings, they use bleach at a much higher percentage than what you would find at home. And I think it's 15%, and you would need, and just 30 milliliters splash on your skin would give you some pretty bad burns. And then there's chemical burns to the eyes, which if you work with chemicals, that can be fairly common if you don't wear your eye pro. So wear your eye pro. And normally you would go over to the flushing station and flush out your eyes, but if you have available, we're going to use a Morgan lens. This is what that looks like. It's basically a contact lens that you can hook up to an IV bag. This person has some ocular burns or burns to the eyes, and that's what the Morgan lens looks like when you are using it. That's pretty much all I've got today for you guys. Hope you enjoy, learn a little bit about burns. This video actually ran shorter, or a little bit longer than I thought. So I'll get it up for you guys and send it out. Talk to you later.